So hello everyone, my name is Hannah Crouch and I'm the editor at Digital Health. Thank you to everyone for joining us today for this best practice webinar, where you lucky people are going to be hearing from the Aneurin Bevan University Health Board, I really hope I've said that right, in South East Wales, which has successfully deployed System C's Careflow Vitals e-observations in 90 inpatient wards across 10 hospitals. However, this is just the starting point, as the Health Board is working now to roll out additional Careflow Vitals modules and to use the Careflow Connect application more broadly. It's also undertaking novel research with Cardiff University using Careflow data to understand and improve the safety and efficiency of processes. So today you're going to be hearing from Dr. Stephen Edwards, who's the Deputy Medical Director and Associate Medical Director for Quality and Patient Safety, and John Frankish, who's Head of Digital Transformation and Business Change. In a change to the programme, we were also going to be hearing from Beth Richardson, who's Digital Ward Programme Manager, but unfortunately she can't make it today. But I'm sure Stephen and John will do a great job even without her, so don't worry at all. One last thing from me, I promise. We are going to be holding a Q&A session after our presenters have spoken. You can ask them at any point during the webinar. So if it's halfway through the presentations or you sort of would like them to expand a point, don't worry, you can ask them at any point. The best place to do this, please, is in the Q&A section, and you can also vote for your favourite questions. And also, if you'd like a question directed at someone, please let me know. Otherwise, I'll just open it to the floor. I'm now going to promise I've stopped talking and I'm going to hand over to our presenters. So it's over to you guys.
Thanks very much. I think we've jumped a little bit ahead, but you probably saw the rogues gallery of who's who. So I'm Steve Edwards, Deputy Medical Director, and I've been SRO of bringing in the Careflow project. And John's with me here this afternoon, and acknowledging Beth, who unfortunately can't be with us, but Adam, as Senior Project Manager, will hopefully be able to support us in the Q&As for any questions. Thanks, John. So just in terms of how we were planning on framing our discussion today, I thought we'd introduce some context around why and where we are and ourselves as an organisation. We then thought we'd give you some of the nitty-gritty around how we've brought Careflow through during the COVID period, what benefits we have achieved and what we're further planning around benefits realisation, what our next steps are, and then obviously summarise and invite some questions. Thanks, John. So in terms of who we are, we're a health board in Wales, South East Wales, so the bottom right of the graph there. We cover quite a large area of Wales and have a population base of around 600,000. So we cover around a fifth of the Welsh population. As an organisation, we're an integrated health board, which means we do primary care, we do secondary care, we do mental health and learning disabilities, and we also have a public health role as well. And we regionally commission some of our tertiary services. So if you like, we're a cradle to grave service for all the primary and secondary care and learning disabilities and mental health services. And to support that, we have a network of hospitals, and also we need to recognise that we interact with 5 different local authorities, which obviously is a representative of the fact of the spread of our population and also the differing needs of our population. We have a wide range of affluent areas and areas of high deprivation. So across the health board, we have a high healthcare need. Thanks, John. So we thought we couldn't really do this presentation without explaining some of our context and some of our planning. In the midst of COVID, we introduced a brand new hospital into our system, and I'll give you a little bit more detail around that. But we need to recognise that we brought in the Grange University Hospital as part of our COVID response, and we opened that site on the 15th of November. The Grange University Hospital, or GUH as it's abbreviated, is our specialist and critical care centre. So for our population, we've redesigned our healthcare services, and I'll give some more detail around that later. But this building is a state-of-the-art building, principally single room, where we have our ED, and we've centred some of our services such as paediatrics, obstetrics and critical care, and our more specialist services and our emergency services. So I think that's an important bit of the narrative, and that was informing some of our thinking around our digital strategy going forwards and understanding what needed to go into the building, but also into the system to help support that. Thanks, John.
So I think it's my turn to pick up the trail, and Steve and I are going to swap this between us so that you don't just hear one or other voice for the whole presentation. So thanks, Steve. I think it's just useful to try and hang a presentation, a digital presentation, on something or other, almost doctrinally, in terms of trying to create some reference points. And it just seemed like a good idea just to use the Vocta report from 2016 to just set this as a reference, really, in terms of some of the principles that were laid out in that excellent report, I think. And then just in this presentation, and there's just four, because I actually will come back to it a bit later on. We'll talk about benefits that we're thinking about, that we think hold true and test Vocta, and just show what a well-written document it is. I think for those of you involved in digital, I think we all share the experience that going live with a health IT system is the beginning and certainly not the end. So we're going to show you and talk to you about how we got started with Careflow, both before and actually during COVID, and then what's happening afterwards. I think because we're talking about benefits, Vocta was, I think, very strong and very clear that return on investment from digitization is not just a financial issue. And Steve will pick up the COVID impact, and then I'll talk about some of the benefits approach and obviously that R&D agenda that we're developing, and we're really quite excited by when you get this kind of amount of data available for you to do things with. And then finally, the action about interoperability should be built in from the start. That's an important principle for us, and we'll come and explore that when we talk about our digital context and why that's really important to us, particularly as we go forward now, well, we're not out of COVID yet, let's be honest with you, but in terms of how we start to frame the future now within our digital context for our hospitals. So I want to talk about the digital context for Aneurin Bevan a little bit. Digital transformation is a challenge for all of us. It's a challenge in all sorts of ways, but getting some clarity about what this means is what our digital strategy is there for, and to help the organization. And we just got that out in 2019, the end of 2019, I think it was, before we started COVID. And there are kind of 4 key elements to it, and you'll see the graphic on the right-hand side. So we have a notion of digital foundations. You've got to get the right infrastructure in place. You've got to have the right services there. You've got to have the right format for your digital organization to support the rest of the organization. That then supports, if you like, 3 other things for us. At the heart of that then is our clinicians and our professionals who are using information, and that's, I suppose, our digital organization theme. About digital community, which is about us reaching out to our patients and thinking about what the future is going to look like in terms of patient-facing applications and work. And obviously the wrap that then provides us in terms of digital data and information that informs other opportunities, both from a clinical and business intelligence perspective. In terms of the relevance for this presentation, I think it's really important to say that our digital strategy was sat on a native clinical portal that we've had for 25 years. And I think it says something about the quality of how that was built and when it was first developed back in the 1990s, that it's worked with us so well and for so long. But inevitably, things have to change. Clinical Workstation, or CWS, is known as highly regarded by clinicians. It works really well, it understands them, and that's because there's been a long active clinical engagement in development with clinicians so that it actually does meet purpose. But it's a secondary care product, and our digital strategy lays out the fact that we need to have a clarity about what the future is going to look. And so we're building a target electronic health record architecture and refactoring the platform that sits behind our Clinical Workstation in order for us to achieve that. And you'll not be surprised that's a technical standard, information standards based architecture using FAR, using HL7 properly in order to make sure and achieve structured data that we can then reutilize. So as a health board, we're not looking to go out and buy an electronic patient record. That wouldn't be right in the context of NHS Wales either. But what we're certainly trying to do is enhance our digital platform with modularized products that give us that leg up, if you like, to deliver improvement a little bit more quickly than necessarily having to do it all for ourselves. And as we look forward, we're seeing this within a digital ward program that will pick up themes of the health record, of how we mix clinical operational data in terms of patient flow, and how that sits within a clinical communications wrap, for example. Steve, I think this is yours.
Yeah, so thank you. So obviously the digital strategy does not stand in isolation. It's there to support clinical service, and this is where the organizational context is key. So we've alluded to bringing the hospital on early, the Grange University Hospital. If you look at the rainbow on the right there, you'll see that this is an understanding of how we approach it as a whole system. So we have our specialist and critical care centre there. We have a network of local hospitals, which is where the bulk of our inpatients sit, but we also recognise that we have care closer to the community, non-hospital based care, and obviously a focus on staying healthy. So the important thing to recognise that we have a network of hospitals there, not all of who have the same infrastructure. So again, a lot of how we manage the patients is that it will be managing their risks, and understanding their risks is key to how we manage these, and they're defining their needs and where they're best met. So the new hospital coming online obviously distilled our thinking and had a target date for us to understand and be able to have whole system information. But as I say, in the context of where we were going, it's a recognition that we need to be based around what the needs of patients are, their acuity, and also recognizing clinically, and my entry point into this was a focus around early and timely management of the deteriorating patient, and obviously having reliable observations that will trigger responses is key to recognizing that group of patients. And then obviously we can define clinical management of that deterioration as that comes through. So if you like, that was my entry point into recognizing the importance of this, and having a structured means that by having reliability and clear line of sight into patients who are deteriorating, we would be able to build a more reliable response across the system, and recognize that some of that may involve stepping up patients. So again, having clear line of sight across the system of where these patients were, what their needs were, as we work across the network of hospitals, that's going to be key. And then the other element of that is there is a key fundamental operational issue in terms of knowing who's in which bed, in which hospital, and clearly that is key. So again, the digital context and the thinking around this and the organizational context was landing towards having a tool where we could understand who was in the beds and what their acute physiology was, so that we could respond to that and deliver the appropriate clinical response. Thanks, John.
So for us, our Careflow story starts actually as far back in 2017 as a pilot. Pilots have advantages and disadvantages. The disadvantage of a pilot is the fact that people think it might go away, so they're perhaps a little bit more reluctant to engage. But it certainly gives you an opportunity to practice and actually spread the message. And I'll reflect on that a little bit later on about why that's been so important to us. And I think particularly during the COVID period. But the platform that built in 2017 and 18 led to a business case that was accepted by the health board to actually roll out Careflow as a product across Aneurin and Bevan, aimed originally, of course, for the opening of the Grange University Hospital just outside Cwmbran there in March 2021. And we had an order of play at that point before COVID, which was we were going to go to, we have three major acute centres, Royal Gwent, Ystrad Fawr and Neville Hall Hospital. We'd already covered off two of those, so we wanted to go to the Royal Gwent because the people from wards and services from both Royal Gwent and Neville Hall were going to go into the Grange University Hospital. So getting those up front was important, and we'd kind of group them together. And so the process was going to be Royal Gwent, then St Willis, and then we were going to start working through our other step-down hospital units across Gwent, finally leading to the opening of Grange University Hospital. But actually all the work's been done because everybody's already using it. So that was essentially what we were trying to achieve at that point. Steve, I think this is yours, is it?
Well, yeah. So I suppose in terms of the context of this, obviously we had a plan, we were moving into the Grange, COVID came along. So I think it's important to recognise that back in over a year ago, South East Wales was really hit by COVID very early in the first wave and hit very fast. So again, after the first wave, we were then in a position where we had the Grange University Hospital building potentially there and able to be deployed as a field hospital, although not completely finished. We knew that we had a second wave on the way, and we understood that our workforce was going to be stretched. We were going to have a high demand on beds. So again, there was intrinsically going to be risk in the system. And so again, driving that bit of understanding where our problems were and how we would be able to respond was going to be key to that. And again, we had, in terms of practicalities, we needed to recognise that it was a very dynamic and fluid situation during the first wave and after the first wave. We had to manage to respond by redefining wards, functions, moving services around to try and separate elective activity, our high-risk elective activity, from our emergency, trying to differentiate COVID patients from non-COVID patients. So again, there was a lot of fluidity going on, but clearly a recognition that there was a lot of risk and that we needed to move on this. And as part of that, there was a decision reached in July that there was an option for us to get Grange University Hospital commissioned and able to function as the specialist critical care centre, which would then enable us to consolidate and bring together the critical care teams to help respond to our respiratory COVID emergency. And again, that felt like the right thing to do in a building that's designed and largely single roomed, plus then bringing together the critical care teams and able to respond to a surge. So there was a decision reached that actually we should be going for early commissioning of the Grange University Hospital, bringing it on stream over quarter of a year early. So again, in terms of the COVID ask, I think we had an intrinsic plan that we were moving towards having system observations and electronic observations in time for the planned operation. But the ask became then, let's get this to manage the system risk, let's pull this forward and respond to the needs as they came through. Okay. So this is the data just showing how COVID impacted on us, and this is the public domain data on Stats Wales. So again, you can see our need to innovate and respond and adapt plans on how we went ahead was very much driven by the work that we were responding to. So you can see, again, when you go back to April, we were already well in the throes of our first COVID response. We were, as I say, we were in a position where the Grange University Hospital, we were in a position where it could be used as a field hospital. Fortunately, we didn't need to use it for that. You can see then, when we reached the decision that we would plan for early opening was in July, and then the go, no go was reached very shortly. So you can see that in the 16 weeks between the decision that we'd go for early opening and the trigger point, you can see the numbers of COVID cases rising, and obviously that was driving our need to get into that building with as much infrastructure resource, single rooms and critical care capacity as possible. But you can also understand the landscape in which we were delivering the training and responding. You could see the fluidity of what we were needing to respond to in terms of our delivery of training, and as I say, the redefining of areas where we could get into deliver training, areas where we couldn't go, and our prioritization of how we managed that risk against a very unstable baseline of what was going on. Okay, and you can see, yeah, on the far right there, you can see where our planned date was for the planned opening. So I think, you know, you can see why we went for early opening. Thanks, Sean.
Okay, so I think that really sets out the context very clearly for you. I'm going to talk now about exactly, you know, what we did and what happened in more detail. And this would have been where Beth would have been speaking to you today, so I'm going to do my best on her behalf. I think we picked out 6 areas really, which we thought we'd want to discuss with you, and just to describe of our thinking really and what we had to do. I think the first thing was clarity of purpose. You know, there's no point trying to do everything. We realized we had to be very focused on what we were trying to achieve. So the notion of minimal viable product really helped us there. It's just such a useful way of thinking about things, just to keep people focused. And we obviously have the ability to introduce Careflow, and we wanted to do other additional modules. In the original plan, there was quite a mix of starting to bring other things in. We decided to cut it right back. It was Careflow Vitals only. That obviously gives you the kind of clinical and ward views that sit within this functionality. It does give us the advantage to enable VitalFlow, which is the bed management system we have taken from System C, but we're not going to discuss here today particularly. And that really allowed us to get absolute clarity on what we were going to go and do, what we were going to go and train on. Of course, it's never a simple process. Opening the new hospital also threw a curveball at the team, which was suitably reinforced, I have to say. Also was asked to roll out Vocera training to support the people who are familiar with it. It's a hands-free communication over Wi-Fi, phone over Wi-Fi eventually, but a little bit more bells and whistles on it, Vocera into that area. I think it's worth thinking, and I think Steve's referenced that already, that it became quite clear very quickly that we were simply not going to just roll out the plan as we had it and as I've described it to you already. It was very clear in April, when we were looking to roll and move, that the Royal Gwent simply was too hot at that moment in time to go in. And people were having to adapt to too many things for us to try and go in there. It would have seemed almost absurd to do that, and indeed we didn't. However, that gave us another opportunity And it just goes to show how in these circumstances, if you're open to it, and Steve was very keen that we should move on to look at one of our other smaller sites and test what actually this would look like in a COVID environment. So we went to Aneurin Bevan, Aneurin Bevan, which is up in the north in Ebbw Vale, to actually do there. And that was one of the first benefits I said of that pilot, really, because there we found nurses who already received and experienced the system in Ystrad, which is in Caerphilly. And we actually got a red carpet ride from them. They were really keen to have the system. It sold itself, and that made life much easier. We then focused on GUH, and it's interesting because initially there was a view you can't go there, that you shouldn't go there. But when we actually went and did our engagement with our senior nurses, actually they said, yes, we can. And you could see on the graph, there was a space and there was a gap. And that's what we had to exploit, really, in order to get ourselves ready for Grange. So we went to the Royal Gwent thereafter. We did also start to roll out to other sites. So we went to St Woolas, for example, which is a step-down unit in Newport, literally just a few hundred yards, if that, from the Royal Gwent Hospital. And we started to implement there, but it wasn't possible to complete. So, there were COVID outbreaks taking place and we had to step back from that and revisit that afterwards. But that wasn't an issue too much because we were able to get into Royal Gwent and pursue that. And then once we got the Royal Gwent out of the way and we got ourselves into Grange, then we've gone back to our plan. We've gone back to our smaller step down units and completed the rollout. So critical to that then was engagement. Regular meetings held with our senior nurses and our site leads in the build-up and during implementation has been key. They gave us the buy-in and allowed our issues to be resolved quickly. You wouldn't be surprised by that, of course. We had to think obviously quite hard about training. We had never thought or tried to do this remotely before. It's been discussed, but we always felt that face-to-face was probably the best way to do this. But we did develop additional digital training materials. We did undertake online remote sessions, and we did continue to do some face-to-face stuff, but obviously appropriately socially distanced in the right places. As a combination, it worked. What I would say is that face-to-face is probably our favorite. But actually having some online remote just buys you enough headroom that you could get through the work that had to be done. From a device preparation perspective, we were fortunate, I think. I think there was a couple of things to say about that. We actually already had, because of the business case, the devices bought and ready to go. So we had a good stock, and we were also refreshing some of our devices from Neville Hall. So one of the device demands upon us was the need to potentially increase the devices on our existing wards so that for infection control purposes, the device wouldn't move necessarily. They would stay in a space. They would be fixed, and we could keep them in the space to be utilized. But because we had enough devices, we were actually gave us some latitude around that. We did order some more to make sure that we were covered for the full rollout, but we had enough time because of that headroom that stock gave us to be able to sort that out, given everybody else was looking at devices at the same time, I'm sure you'll recall. We split the work though in terms of device preparation between our mobile team that looks after all our mobile devices who do the essential configuration, and then the Careflow team. There was an established pattern for doing this in terms of enabling them immediately for use on the wards once we'd received them. And finally, there was the team itself. There was, it would be fair to say, considerable team anxiety. This is a relatively junior training team in terms of grading, and there was an associated anxiety, I think, about what that meant. So we had to look after that. A lot of the COVID infection control guidance is great. If you're a clinician, you can consume it. You've got to help other people to consume information in a way that's appropriate to them. And Beth and Adam worked with infection control to develop a very clear standard operating process so that we could overcome those issues and actually work together. It being COVID and it being the NHS, and I'm sure you'll all experience this, everyone pitched in. It was a terrific team effort. There's no question from start to finish. We did get some extra support for Sarah, and we're very grateful for that. But in summary, I think the team adapted superbly and were able, as a consequence, to provide safe and effective training, by expanding how we did our training, but recognizing actually what core value was. And we were able to provide on-site support and do some face-to-face thing. We weren't doing it on the wards. It was, obviously, you weren't going to go into a red zone area to do that, but we did find places we could do that effectively. Hopefully that's the next slide. Here we go. So a couple of summary views really on what we did then, just to give you an idea of the scale of what it takes to roll out to, in the end, 90 odd wards. So during the period of April 20 to March 21, you can see what we've covered off in terms of 1,500 staff trained and further staff since the implementation, the number of sites where we've actually covered off in that period, the total additional wards trained. I'm not sure our numbers add up. It is 90 wards. I have done the numbers on that, so if it doesn't quite add up to what you've seen on what we'd already done, that's always the numbers. And you can see the large number of devices we've now got on the floor, which give us a tremendous advantage actually in terms of that. But actually between April and November, we actually did 2 additional sites really, which was Aneurin Bevan and the Royal Gwent Hospital. We did try other spaces and we did get things set up, but we were then able to do that. We had established what we had to do, which is get ready for Grange, and we achieved that. So in summary, in terms of success, looking back at it at the end of that plan, and the plan was already to get this done by the 31st of March. Well, we did it, and we did it in a different order. We are now in 90 wards. We're in our medical assessment and minor injuries units. We're in our adult medical and surgical inpatient environments, and we're in our step-down rehabilitation units as well. So the essential is there and in place, and that's giving us obviously the ability to see acute deteriorating patients. But because you're doing this electronically, it gives us critically the admissions, discharge, and transfers, which give us a proper live bed state, so we know who is where in terms of supporting the bed management of our hospitals. We are not yet in pediatrics and in, for example, maternity. They are actually options on the contract for us. What we're waiting to see is the outcome of the order hay work that I know that Careflow are involved in, and also the national picture for pews, for example, from a pediatric perspective. And actually for our maternity, we're concentrating on looking at a new maternity care system at the moment. So that'll come back a little bit later for us, I think. We are in 10 hospitals. You can see what they're all there. You can see where we went first before 15th of November and where we've been since. Those are quite small. The other ones are actually quite relatively small units. They're 2 or 3 wards in each space, or even 1 ward in one case in terms of the North Rumney unit, which is actually quite a small GP-led unit. But it just gives you the sense of how we've got a complete picture across our patch. We have achieved our MVP. So we've got Careflow Vitals in, Vitals Plus, clinical ward, so people can see stuff and they can see it pervasively from anywhere. VitalFlow has been enabled for bed management. What we haven't discussed here is we did actually do a Careflow Connect pilot. It was an option on the contract and we triggered that. I'll come back to that in a little bit. We have over 900 devices in use. We have a mixture of mini and iPad minis and iPad Airs. We did actually start with iPods, but they've gone now. And we do have large screens and a plan to implement further large screens to enable us to start to utilize these kind of spaces to support our multidisciplinary team meetings. And a small little benefit was we suddenly realized that we didn't have Wi-Fi at Monovale. We do now. So that's quite a nice thing to have happened. So that'll give additional benefits to that unit. So success factors and lessons learned then. I think one of the success factors was that clinical input, that need from Steve and his clinical colleagues about the need for information in light of COVID, and that certainly boosted engagement and uptake. And I would say also the fact that we had engagement with our site leads, and we'd done the piloting work, which meant we had people out there. One of the interesting things that happened in Royal Gwent was there was a reticence to go in there and say you mustn't go there. When we engaged with senior nurses, people who had already been working with the Neville Hall saying no, we need to have this, we want to have this. Actually, it made it an easier ask in the end for us, and we were able to do it in the window that we had. Team delivered training successfully in some very difficult scenarios. I think that's down to the team as much as the other support we put into it. Our online resources and sessions, it gave us headroom. It's not perfect, but it gave us headroom. It allowed us to do things. It gave us a space to do that. And obviously, we had worked out how to manage devices so that we were well configured ahead of time to avoid bottlenecks. And of course, critically, is our staff underpinning it all. I can't emphasize that enough, and I'm sure you'd all agree about that in terms of your own experiences. Lessons learned. Online training centers were relying on us having suitable tech. As you know, hospital walls are not always equipped for being training environments properly for people doing this kind of stuff. So that was a little bit of a point. So something to think about really for us in the future. we're very keen. We're very keen on doing proper benefits realization, but I'm afraid that was a casualty of an expedited rollout. We're coming back to that. I'm going to comment on that in just a moment. Interesting about that value of face-to-face training versus socially distance. Equally, our ability to evaluate the implementation has been a casualty of the expedited rollout, and we're going to go back and look at this now. We're just doing this at the moment, just starting to work that one out, how we're going to do it. We really want to explore some of these things and just say, well, what was good, wasn't good. You've heard it from me, but we actually need to, that's what we think, but we need to go and confirm that. What is clinical grade Wi-Fi is always an important question. Actually, our Careflow devices operated very well in the new hospital. We operate in a Cisco environment, and obviously we're using the Apple devices that are aligned. We have a national mobile policy that says quite rightly that we should be device agnostic. However, that came in after we picked up on using Careflow. It is certainly important that that if we go back and look at this again, I was only literally talking to our infrastructure program manager today, that how do you ensure that any kit you're buying meets your environment? You're building proper requirements so you can test those things out in procurement so they do really work. We're buying a software application. Have we really thought about how the kit's going to work in our environment as part of that? And I think I was going to go back to that again, buying in software services again, then thinking about that device is a little bit more detail. I think is really important. But fair play, you know, the Wi-Fi worked very well in that environment, and we've learned a lot about device use case. I think sometimes you can get caught up in the weeds of device use cases because everybody thinks they've got a separate use case. But for us, in the end, it comes down to two clear use cases. For people who are working in a fixed environment, such as a ward, we found baton devices work fine. We've never had any issue with that. And we have done evaluation, by the way, on our pilot sites. We had no issue with that at all. It works well. We have enough devices on there to support people on duty for charging, and we also have other devices for people coming onto the ward. And then for peripatetic stuff, yes, they do need individual devices. One of the things I should have said, and one of the reasons why we had plenty of stock in at the beginning of this, was we're planning to give a device to each of our consultant teams for them to take around. Well, we've got to come back and sort that out. But actually, we know that's the right way to go now. So there's quite a lot in terms of that use case for us. Steve, I think this is yours.
Yeah, so obviously we made life quite difficult for ourselves by doing this. So why did we do this in the face of COVID? A, because fundamentally it's the right thing to do, and it gave us some really important eyes and ears. So COVID put obviously the system under a lot of stress. The clinical teams were very stretched. So it was one of the key benefits was at the individual patient level, we knew what their observations were, so we could understand and obviously be triggered and alerted in a structured way to any problems. In terms of ward-based levels, obviously it gave us a sense of what was going on in the ward, and scaling that up to whole system, we could define the acuity of our inpatients across our whole system. We were dealing with a major respiratory condition, and we could answer simple questions such as how many patients we got on oxygen. And we could answer that very quickly instead of sending people running around with clipboards. So again, in terms of the information it gave us actually developed some clinical intelligence. So again, this was a really helpful tool in terms of defining the acuity, what were the news scores of our inpatients, where were our high risk areas, where were our low risk areas. And again, we did some other work around dependency of our inpatients. So again, it enabled us to triangulate to the acuity of the inpatients, the dependency of the inpatients. And again, taking that forward, there'll be work around kind of aims of care for individual patients. So again, triangulating acuity, dependency, and what the intentions of treatments are for individual patients is going to be fundamental. That was fundamental in COVID, but also that's fundamental going forward. And I think one of the key messages around this is that it is the bedrock for the additional functionality, and it is our fundamental anchoring point in terms of knowing which patients are in which beds and what their observations are telling us. And that then is obviously allows us to put the additional function on, but that for us is the key bit across our hospital estate and our whole parts of the system. Where are the patients who are deteriorating? What actions are we taking? And again, having that whole system line of sight of where our problems are and enabling us to respond. Thanks, John.
Okay, I'm just conscious of time moving on. A couple of slides really on benefits realization, really. Just about benefits assumptions, identification and realization. I've already made reference to the fact that this really matters to us in terms of really demonstrating the impact of that. But just some reflections on that right now. I think first of all, benefits realization, and going back to Voctor, actually, I found this a really useful quotation. history of organizational digitalization teaches that cost saving may take up to 10 years or more. Now, previously I was a national program manager on patient flow. We wrote a business case around these kind of things, and we actually use that to inform the business case for Careflow. I think, you know, we've got to be sensible about this. We ask at the moment, well, why haven't you delivered the benefits? I mean, number one is there's something about what IT delivers. We enable, we create a space, and the benefit actually needs to be delivered through the business change in the service and organization. But then there's also about when is it going to happen? So let's take Vocto as our starting point in terms of being sensible about that. Certainly in the first year, you're not going to see anything. And it's interesting, and the evidence base, I think, supports it, that you may well see some efficiency losses, certainly in the EPR evidence base that I've seen that's developing. So we've set ourselves some targets, but of course these things can change, and you know, all plans fail with first contact to the enemy. So we're going to see what happens. 33% benefit in the first year. We'll see what happens, and so on. You can see that there. I suppose it gives us a frame of reference. Important for us is we've got benefits sitting in the Careflow business case. We need now to draw a line through that as we go forward and actually retrofit our work into what we've done to date. But I think I'm so glad that we put nothing in the first year, because I think that's very honest and realistic about how you do things, and I'm sure we may be changing that again. I don't think 10 years will be acceptable to anybody, but it's just a work on the ground. So look, we use a proper benefits management approach. We have a benefits framework that we're utilizing that's based on Jenner et al. And people like that. We're looking to map benefits, and this is just the Careflow Vitals aspect of that. You saw on the other slide the full map as it's looking at the moment. We can use this to provide a very simple, you know, red, amber, green view of where we are with things, just to give us a sense of it and where the work needs to be taking place, probably, well, in the first place to actually deliver our benefits. But this is just a front up view for us in terms of how we're seeing that. The project output, the capability that we're anticipating, what that means in terms of outcome clinically, what the benefit of that is, and how it relates into our investment objectives. And again, we were well served by having a national program where the business case had identified what those investment objectives look like. And we actually have more information on side of that in terms of things that relate specifically to the health board and its strategic objectives. The beauty of this approach, of course, comes from looking at benefits dependency, because you can take out the outcome and you can start to track the capability in terms of the business change you're looking to achieve that will give you the benefits. And I think this is a magical way of actually thinking about this and structuring our thinking. And actually this kind of work that we're looking to proceed with now really gives us the insight we need to focus on where we think business change needs to take place. So if as we've got this kind of COVID force retrofitting, clearly, we've got ongoing work for integration. Careflow Vitals pumps out, you know, structured data into our data warehouse. We haven't yet worked out getting that into the health record properly. The point about having in a data warehouse relates to the last point on this slide, which is about the ability to develop business intelligence. We have ClickSense as our tool. That's what we're going to be using going forward to help our people to understand how the system is operating based on the insights we're getting. Benefits ownership is obviously critical. It's not just the SRO, it's not just Steve Edwards who's sitting there. He'll be glad to hear that. A proper benefits process gives us the opportunity to sit there and say, against any given benefit, not only who is the recipient of that one, but who owns it, who has a responsibility to actually make sure that things are happening out there, and that they can find the right business change managers to help them to release those benefits. So he's doing the right change. I think for me, as we look at this, it's about clinical policy alignment is the next thing that really, really matters for us. Careflow is properly configured to our health board deteriorating patient policy as it stands. That doesn't necessarily mean that your deteriorating patient policy is necessarily properly digital fit. So, you know, we discovered a gap where patients on continuous monitoring were being recorded on paper and were not having their information regularly uploaded into Careflow so we could get that full picture. Well, that's something you can resolve quite quickly. And if you've got a policy in place and you've got to keep up with your practice education, you need a recognition that practice education is really important to this. As we started Careflow back in 2017, we realized that we were going to have to do quite a lot of re-education work around just actually doing essential vital signs observations. So people were very clear about it and what their roles and responsibilities were across our healthcare support workers and our registered nurses. I think critical above all else of this, that's all great, but it's got to fit into a space in which you can do the work. We had a user group in place before COVID. You will not be surprised that that had to stop because of COVID. People had other things to do. So we had to do the basics to get this running. We're going back to that now. We're just establishing proper clinical chair and representation in there, as well as operational representation, because that's got a two kind of function role here for us. Yes, it's about benefits and it's about clinical service improvement, where we can talk about benefits and business change and actually how we're going to do that and deliver service improvement as one of our key methodologies for that. But it's also that other side to ensure that we're using the system safely and that we're getting user-led requests for change. And it's got a dual functionality in that space. And I've mentioned the business intelligence tool, so I'm going to move on from that one fairly quickly. So that's what I've got to say about benefits. I think some cool stuff, really. What's next? Well, research and development is what's next for us as well. There's a huge amount of data that comes with this package. I mean, just profound. We've already got an eye on the fire with Cardiff University in the Computer Science and Informatics department, and their something called the Cardiff Unit for Research Evaluation, Medical and Digital Education, Dr. Liam Turner and Professor Alison Bullock. And we have postdoctoral research looking at behavioural insights from the data. I'm going to show you a couple of slides where that is. And we also have a PhD looking at the impact of mobile technology in the clinical workspace. There are, we're throwing a lot of digital kit in here. What does it actually mean for people? This is a people space, not just a kit space, not just a technology space. So we're interested in looking at that and working with Cardiff on that one. We've also had the opportunity now, literally in the last couple of weeks, to pick up a PhD, or MSc initially, and PhD students from Swansea University, working with the Computational Foundry, which is led by Alan Dix, who has got a world-renowned recognition, I think, for human-computer interaction and an interest in machine learning, artificial intelligence. So we're going to be doing some work around sepsis and that one. That really is helping us to understand what the opportunities might be. I don't think we're necessarily expecting to have an AI tool that will be utilized across the world in 3 years. I think it would be slightly naive, but it's a real opportunity, isn't it, to learn for us, given that there is work in this space. So we're looking forward to doing that and supporting the student with information in that space. Steve, I think this is your slide.
Okay, so again, where are we going next in terms of what are our next steps? Careflow Connect is something that we've embedded in my clinical practice in intensive care. So again, it's something where we've explored in smaller areas. So again, the pilot in intensive care in terms of that understanding and the narrative around the patients, the tasks, the actions, and that's been really supportive, both in terms of the clinical team, obviously dealing with a surge and a lot of patients. So having that touch point in terms of narrative around the patients and people having access to that so that there's a shared understanding. And also recognizing that we've had some remote staff, working staff who've been supporting communication with families. So again, they've been able to access the communication in terms of understanding where we are, so that where the team was the clinical team was under pressure, they've been able to support families by having that narrative and that touch point around there. So again, we've not focused it across broadly, but again, it's that bit around actually our thinking in terms of functionality, in terms of what are the issues for patients, what are the tasks outstanding. And again, that's the next step for us in terms of that thinking around additional functionality and what can be released. And again, that's around that clinical narrative and the clinical need. Again, we're looking to develop that into a digital ward program. So again, instead of it being, if you like, a standalone project of observations and bits that we can add on, actually fundamentally looking at the ward, what a digitally enabled ward is and what that actually means in terms of delivery of clinical care. Because as I say, for me, it's around the integration of the digital thinking into the landscape of how that impacts on care delivery and how it makes it more effective and reliable. Thanks, John. So in summary, it was only when we actually started putting this slide deck together, we realized how much ground we'd covered in quite a short time and some of the stuff that we needed to move around really quickly. So I suppose for me, it's to acknowledge the team who've delivered on this have done a fantastic job under really difficult circumstances. And I think it gives us a great opportunity going forward that we've got the bedrock of observation, which then is allowing us to have these discussions around additional functionality and understanding what's actually going on. So I think we're on to questions now.
Lovely. Thank you very much, Stephen and John. It's a really, really interesting presentation, actually. Lots of information to digest. We've got just over 15 minutes, or just under 15 minutes, I say, for questions. So I'm going to rattle us through as many as I can. The first one that we've had was quite interesting from Nigel, which says, what's been the feedback been from patients, and how has the patient experience and engagement improved as a consequence? Who wants to go first?
I think I'll take that. Actually, way back in 2017, there was an anxiety that nurses running around with digital devices and looking at them would be somehow perceived as being somehow they're not doing the work, they're looking at their phones, and perhaps using an iPod Touch gives you the wrong impression. One of the benefits of moving to an iPad Mini was there, but we very carefully actually publicized in advance what we were doing. And I heard this as a national program. I heard this fear about, well, people are going to think we're not doing anything. We're looking at our phones. I think it's a concern that we can set aside. It did not emerge as a critical issue at any point that we've had people worrying about people using mobile devices. And I think the world has moved on a little bit with that one. But we did prepare for it, and we did make sure that was communicated out to patients towards, and we put posters up everywhere. I remember doing that to make sure that case was made. During COVID, we didn't do that. We didn't have time to do it, and I don't think we needed to do it. I think it's a done deal. In terms of patient engagement, well, this is very much on the staff side of things, in terms of staff, collecting information as they would on paper. So for us, that's not a critical issue in terms of how we do that. Obviously, we talk to our community health council about IT things, and I don't think that's been raised as an issue. I think it'll get more exciting once we get into that digital community area of work, when we're actually using patient-facing applications in a very different way. But I hope now there's an expectation of the public that we should be doing this. They should expect to see professionals using digital devices to support their care.
Yeah, and just to echo that, there was nervousness. There were a lot of posters put up. There was a lot of comms went out. But again, in terms of what are we delivering with this? We're delivering, more reliability, clear line of sight on what's going on with the patient's obs. So I've not been aware of any adverse comments from patients in relation to it.
I think definitely the argument's now shifted from they're worried that they're looking like they're not doing their work to people just assuming now that they should have phones and iPads and everything. So yeah, that's jogged my memory actually, because I do remember that there was that concern that people were like, oh, they're just going to think I'm playing like Snake or Tetris or something. So
it's nice if you can label your device with a big NHS sticker.
Yeah, exactly. Yeah.
But then infection control get upset.
Yeah.
But then infection control get upset. So there are things we have to think about there, but it's not an issue anymore.
Next question we've had from Claire. She said that I see you had engagement with senior nurses and managers. Were they communicating with ground floor staff, and how did they adopt this under pressure? And what was the appetite for the change at the time? There's a lot of questions there, so take your time.
That one? Do you want me to take that one, John?
Adam, yes, please. Adam, the project manager, will now talk.
Yeah, so I mean, the senior nurses did communicate with the ground staff during our implementations and the planning phases, but we would also liaise with multiple levels of nursing ourselves. We would just ensure that the comms were flowing and there were no bottlenecks or gaps around that as well. So in the first instance, the nursing staff obviously were a bit hesitant with regard to the ability to release staff in the light of the situation. But on the flip side, they were keen to get Careflow in due to the benefits with regards to identifying deteriorating patients. And I think as time went on and each site went live, we kind of honed our approach and we were able to communicate this across nursing, and they were able to obviously speak with their nursing colleagues as well as we were doing that, to share how we would fully implement this, which allowed them to see the ask, what we were asking them to do, how they would need to release staff, or the opportunities as well for us to offer an online option if they were hesitant to be able to get staff from, say, the ward area up into a training room, which could be a 5 to 10 minute walk. So yes, there's definitely appetite for it, for sure. I don't know if John, any more you want to add on that? Or
no, I think you've answered that beautifully, Adam. I have nothing to add to that.
No, and I think we do recognise that between the COVID surges, we were having nursing staff moving across different sites. So again, if they went to a site where it wasn't in, there was actually an internal appetite for let's move on with this. So again, I think that's quite telling, isn't it? That when staff have been exposed to it and been using it, they don't want to give it up.
Absolutely.
So another question come through is about, because you mentioned obviously about iPads and iPad minis and all that things, and Reese is just asking, did that create any disparity with any of the PCs in the existing estate?
Do you want to say that one as well?
Yes, please.
So I don't think so currently. I mean, the PCs that we've got are static and including our computers on wheels as well. are still utilised fully, as our clinical portal is primarily accessed from there. And our clinic portal includes integration with a lot of our other clinical systems, including actually a view of the TPR chart that is generated by Careflow as well. Now, obviously, moving forward, there is work ongoing to bring those systems into a more mobile environment, which is perhaps when we may see that disparity more. But I think at this moment in time, the kit that's been provided from iPads to desktop PCs are all still being fully utilised.
Yeah. And I think there is an element around understanding function, isn't it? Because clearly what's at the bed space is very much around immediate observations. When we're looking to kind of do radiology imaging and so forth away, not in the immediate adjacency of the patient. So I think it's in my simplistic world, it's horses for courses in terms of the devices we've got.
Yeah, I agree with that. It's clarity of use case, isn't it? I think we've got clarity of use case in terms of the iPad, or the Apple devices in this particular space. But I think notionally there's a broader device ecology, as I would call it. The kit you need in a ward to allow people to move that. You're moving from hundreds of pieces, or thousands of pieces of paper, arguably, down to actually a series of such devices which have to be designed to meet particular use case requirements. And I think Steve's popped that on there in terms of the radiology one, in terms of what the screen definition is now. And iPad's not bad actually for some of that work, as I understand it, in terms of the work we've done on that. But these, a ward round is different to something where maybe a junior doctor's doing their own little round, for example, doing a round to what a nurse is doing, or what even a physio or a therapist is doing, coming onto the ward and picking up materials. But having the devices there gives us a lot more latitude as we go forward for mobilization of our portal, for example. We've already had a version of that out there, and we're looking to actually increase and enhance that capability. And we've got the ability to allow people to have that patient in their pocket, as I always call it. That allows you to flick it out and see wherever you are what's happening with that patient, so you've got information in real time and where you are.
Another question we have come through said, how many trainers and system configurator specialists did you have?
Adam.
I mean, I'm not sure how exact you can be. I mean, I'm not expecting a kind of exact number, kind of a round number, it's fine.
Round it up from the decimal point, Adam.
Yeah.
Well, I mean, from a training perspective, we had 7 trainers. And as John had kind of mentioned in the presentation, a lot of them were relatively new coming in as well. So, we had the 7 trainers in place there. A lot of them a few of them have been in place already for the Neville Hall implementation and the app implementation. But the majority of them are coming in fresh as well. So we had 7 trainers and 2 config specialists in the form of 1 product specialist and a senior product specialist as well. So, it's a relatively small team, which is, with what we look at what we've managed to achieve in such a small time scale, when you kind of step back and have a look at that, we've been eternally grateful for the team that we've got in place.
It's certainly asking questions for us about how we continue to get the benefits of a training team of that in terms of our other products are out there and how we actually utilize that. Our training resource generally has been very small historically, and actually having that has been enormously beneficial. And it's something that, as part of our digital strategy, we're looking at quite carefully in terms of our ability to continue to commit to training, because I think that's critical, isn't it? And we get so much, you get so much staff turnover, and the ability to be there for them when they arrive and to set them up properly is really critical, I think, in terms of helping people to utilize the technology. And and there's a lot of technology, and it's quite a pressing issue, isn't it, really, in terms of allowing people to come in. And not all technology is the same, regrettably, from place to place. It doesn't need to be necessarily, but you certainly need to help people to get eyes on things. So it's a really important item for us.
Okay. I've got a few more questions left, hopefully trying to get through all of them. Ashford said that they really liked how you phrased benefits being a casualty of delivery. So this is something I've seen in my experience over and over again. How do you think we can avoid this in the future, or basically, in other words, any lessons learned, really?
Well, I think that's a question for me, because my job title is Head of Digital Transformation and Business Change in the first instance. You need to agree that this is the focus of how you're doing transformation, and that needs to be, I think, more broadly in an organization about how it's thinking about transformational change. It shouldn't just be how digital is done. I think we have 3 modes of management is what I say these days. Business as usual, service improvement, which is, if properly targeted, can be tremendously effective, but it's different to, let's say, the enablement of larger transformational change at service level or doing digitally, where it needs a proper MSP or Prince2 type of wrap. And I think I come as having been a nurse and not understanding these things, and now I've been in this space, I really see how those things are important. So benefits needs to be understood not just by digital. You need it to be understood by everybody, but you need it to be understood within the context of transformational change that you're trying to achieve as an organization, doctrinally to be part of your strategy. And that helps you do it. So it's how do we break out from a digital transformation space into that broader organizational improvement space and help make sure these things are properly adopted. We employ a lot of clinical managers who are, I was a clinician, I was a nurse. You know, you're trained as a nurse and you're not necessarily trained comfortably in that management space. There's quite a lot of work we need to do to help people with that. But, you know, in terms of the engagement work that we're now focused on, which is building proper planning, we have something called an integrated medium-term plan. That's that, you know, helping people understand that we're going to engage with you and we're going to use these methodologies within which benefits is going to be, you know, benefits ownership, benefits management is going to be really critical, is the way to overcome that. And I'm afraid it's about repeating that story over and over and over again until you get it. I think my wife would say it's a bit like introducing food to a small child. It could take 20 times before you do it, but you've got to do it. You've got to keep doing it because there's a discipline that will pay off in the end. And as I go back, I love benefits. I used to say, oh dear, benefits. I love it now. I'm obsessed by it. You know, the idea of you build a map, you test that, you trial it with the service, you get the ownership embedded with it, and then you help them to build their own business change plan because they can see what they've got to do and own it. That's a really good way to proceed. I mean, I just regret that we haven't been able to do that in the way we'd wanted to in this space, but we wanted to share with you exactly why we're doing that and why we're thinking it, because we think it's so important.
Just 2 more questions, I promise. Another question from Claire saying, how have you avoided digitizing an existing broken process or workflow? I mean, if you can answer it lightly or briefly.
Let's look at observation. I mean, I was a service improvement person before I got involved in digital. And what we found is service improvement has focused quite a lot on key clinical areas such as infection control, pressure sores, management, tissue viability, things like that. And one of the things that we've suffered with in vital signs environment, and particularly around sepsis management, is the inability to actually see things at scale in real time. You know, you're trying to do sepsis management on the back of paper audits and other bits and pieces with potentially small teams. Well, suddenly actually digital is transformative because it provides you that real-time information. So you don't have to do that kind of work, and you can release those staff to think about what service improvement needs to take place because you've got the data in real time. Now, our journey around our additional modules with Careflow, and we're looking closely now at using the Sepsis 6 module. We've got some decisions to make. We've got the core in there. What do we do next? Do we just jump into Sepsis 6? Actually, we're going to jump into probably fluid management next, because we know getting that right as a foundation is the best way to do this, because again, that's not visible to people either. And speaking as a nurse, and we've all done our midnight tallies of fluid balance and how well it's being done. You can't see that at scale, so you don't know what kind of problem you've got. So vital signs has been, I think, a bit of a hidden problem. We tended to look at sepsis 6 forms rather than looking at that. We did do both, I have to say, we did absolutely do both, but it's not easy to do that. I would say it's not that it's broken, it's just an opportunity that's gone wasted until you've got the right technology to be able to see it and fix it. So I don't think that's been an issue here at all. I hope that's okay, Steve.
I'm sure.
Yes. No, I think visibility is key, isn't it? Because clearly we have visibility of what observations are being done on what patients across our system now.
Yeah. And then just one final question. What happens how do you access the records if the networks goes down, is a question from James, which is the big question.
Do you want to talk about that, Adam, in terms of the functionality of Careflow, in terms of its caching and things like that? Or
yeah, so with regard to Careflow, if the device become offline and not attached to the network, they do have the ability to enter data, and it caches data then for a number of days. I believe it's 5 days. So you're still able to take that information against that patient, be able to see the trends through there. As a precaution of that as well, we also look at implementing business continuity with regards to dual running if required as well. So there is a trend on paper as well.
So I think that's as it is. I think this is something you always want to come back and keep looking at. You know, we're aware of colleagues looking at e-prescribing who find that a sharper issue, and they're putting in kind of network PCs, but they're Wi-Fi enabled PCs with battery power packs to deal with that. So you obviously got a cache of the local record, and can you do that? And funny enough, we've just been talking about this morning about, well, that's something we need to look at and think about. But at the moment, that's where we're at with it, and we've got a very clear business continuity plan that is part of the rollout and deployment for any area.
Lovely. Well, that's all the questions. I think we timed it pretty well there. And I think we're going to have to wrap it up as our time's up. But thank you so much to Stephen and John and to Adam for stepping in at the last moment. Thank you very much. And thanks to everyone who's tuned into today's webinar. Just a quick plug from us. We've got a packed schedule. If you've enjoyed today's webinar, we've got plenty more webinars coming up in the next few weeks. So please do head to Digital Health's events page and register for all of them if possible. I know kind of giving up your Friday lunchtime or Wednesday lunchtime is very precious, but I'm sure they're worth it. And that concludes today's webinar. Thank you to everyone who's joined us, and thanks again to our panel.
Thanks very much.